Good afternoon. I'm Steve Selps, a Quill Healthcare Executive Consultant. I've been a healthcare consultant for about 15 years, and my expertise is in payer contracting. I've negotiated somewhere in the vicinity of about 15,000 health insurance payer contracts. I'm joined today with my colleague Nicole Medina, and the two of us will be your hosts for today's second quarter Quill Healthcare webinar. And this is on a topic about value-based reimbursement, a very critical topic in our healthcare ecosystem, and a critical topic that will, if it's not already important to your practice, it will rapidly become important and begin to affect a much greater percentage of your reimbursement than ever before as our healthcare system shifts from basically a 100% fee-for-service system, with the exception of HMOs that are often capitated, but moving into a reward-based system based on clinical care and business metrics. So we're going to talk today, and Randy's going to explain a lot about this evolution of value-based reimbursement. Quill Healthcare sponsors these webinars, and one of the reasons that Quill sponsors these webinars is that Quill, besides being the leading provider of medical supplies and office supply products, is very, very focused on providing its customers, you, as practices, with value-added services and information that can help you effectively run your practices and to be more profitable. And certainly, value-based reimbursement fits extremely well into that goal. And I'm certain that today you'll benefit from the valuable information and interaction that you have with Mr. Randy Shulkin, who will be our featured guest speaker on today's topic, Value-Based Reimbursement is Coming, and How to Prepare. Now, before I give Randy his proper introduction, I would like to cover a couple of administrative matters that will help all of us to get the most out of the next 1 hour session, and also help you to have several options to interact with Randy at different points in the session, as he will be pausing at least twice, once during the session and once at the end, to take your questions. And towards that end, you can actually ask questions either live over the phone, or you can ask questions by simply, at any time during the session, sending your questions to the email ID that you see here, question@healthsense.com, and Nicole will be constantly monitoring that email ID for your emails, and during the breaks, she will be prepared to cover the questions that you send to that question@healthsense.com email ID. Starting now, feel free to send any and all questions or comments that you have to question@healthsense.com, and we will be glad to cover those questions during the session. Also, during the breaks, what you can do is I will prompt you to press *6 on your phones when you would like to ask a live question over the voice system during the webinar. And then when you're done, please press *6 again on your phone to mute your line. It's as simple as that. *6, converse with Randy, *6 again, and you're done. So that's pretty much how you can do it. Either send us an email, or during the breaks, *6 and then *6 again when you're done. Also, if you lose contact with the home base here, which is join.me/healthsense, you may simply go to join.me/healthsense at any time during the webinar, and your session will be restored. Just go to it from any standard web browser on any platform, PC, Macintosh, various phones, etc. All of that works. So join.me/healthsense. And by the way, the Android phones and the iPhone also have an application for Join Me if you prefer that route as well. I mentioned before that at the end of the session, within 24 hours, and actually it's available now, you can go to healthsense.com/copies to get a PDF version of the slides that Randy covers. And at a later date, we will inform you of the Mechanism Resource Center where you can go to obtain the actual video of this entire session, which is being recorded. Now, without further ado, I would like to introduce our featured speaker, and that would be Mr. Randy Shulkin. Randy is an MBA, FAC, MPE, and he is an executive consultant with Colbert Healthcare Solutions, a Massachusetts-based healthcare consulting company. Randy has more than 30 years of experience in all facets of physician group practice management, including new group development, M&A, that's mergers and acquisitions, strategy, and process improvements. His experience includes serving as a senior executive for both private and hospital-based and hospital-affiliated medical groups. He is recognized as a fellow in the American College of Medical Practice Executives, and it is with great pleasure that I turn the floor over to Mr. Randall Shulkin. Randy, take it away.
Thank you, Steve. So the business of medicine is changing, as we all know. Today there are more acronyms for regulations than there are for diagnostic tests. ACO, MSSP, ACA, the list goes on, and there's more that are coming about all the time. We will talk about the most relevant ones to the significant changes that are upon us today. And we'll spend part of our time also discussing the basics of value-based reimbursement, and then what you as a medical practice can do to better position yourself for success in the future. And I'm not going to read the slides to you, since you can obviously do that yourself, so you can see what you can see the key issues that we're going to talk about, and I will pull relevant information off the slides, but I will be using them just as a view as we're talking. So we can go to the next slide. And why is value-based reimbursement come about? Well, still today, most physicians are being paid based on the volume of services that they're performing. Fee-for-service. You perform a service and you get paid. Quality measures, if you have any in your contracts today, are really a small component of compensation. Usually, less than 10% in most cases, if there's any at all. Costs are continuing to increase. Under fee-for-service, there's no incentive to actually control costs. You do more, you get paid more. Your health insurance premiums are increasing. Not just your patient's health insurance premiums, but yours. You're paying more today in health insurance for your staff than you have been in the past. And you're getting less. The deductibles are going up, co-pays are going up, and the hassles in terms of regulations and authorizations and all for CTs and MRIs and the like are all making it more difficult to be able to perform, and reducing the number of services in some cases that you're getting. From 2015 to 2016, the silver plans that are in the marketplace for the exchanges that are in each of the states have gone up on an average of 4%. Some states have gone down over 10%, in other states they've gone up over 16%. On average, today, the average premium for an individual is now $6,000 a year and over $17,000 for a family. So from 2005 to 2015, premiums have gone up over 61%. The employee contribution has gone up over 83% during that time. So value-based, and that's based on information from the Kaiser Family Foundation in surveys and studies that they've done during that time. Value-based reimbursement is focusing on reducing costs and increasing outcomes. So the Affordable Care Act, or Obamacare, as you know it, focus has been focused on increasing the growth of this value-based reimbursement. And you've seen there's a growth of the ACOs and MSSPs with Medicare and other insurances, and I'm going to talk a little bit more about that as well. So the Affordable Care Act has had 10 major goals. Some of them have been repealed or overturned in the Supreme Court, but many are still in place. So one of the primary goal has been for quality affordable care for all Americans. We have millions of more people on the rolls for healthcare today than we did prior to. The role of public programs is increasing the role of public programs so that you have more people that are eligible for Medicaid or Medicaid-like programs. You have improving quality and efficiency of healthcare, prevention of chronic diseases, so that you're through some of the different programs that we're going to talk about. The workforce. As many of you know, we've had in the past, and we continue to have today, a shortage of primary care physicians. And one of the components or goals of the ACA is to improve the motivation for folks to go into primary care and to help in that process. Others are transparency and integrity, so that, as you have seen, hospitals are now having information being published by Medicare. Medicare is publishing how much physicians are being paid. The pieces that get the news are the top 100 physicians as far as what they're getting paid by Medicare over the past several years. Improving access to get patients in to be seen as opposed to emergency rooms and the like. And strengthening quality and also maintaining revenue for the physicians, but also to keep the revenue at a level to keep the cost down. So one of the key components of the newest regulations, the newest rules that have gone in place and laws, is the Medicare Access and Children's Health Insurance Program Reauthorization Act, or MACRA. MACRA is what was just passed over the past year, and it had one of the key components was the repeal of the sustainable growth adjustment that was in the Medicare law that started with RBRVS back in the 1990s. And the SGR was the component that over the past 15 years or more is why every year we would get to the beginning of the year, and Medicare would come out and say, oh, now we're going to have a 20%, then a 22%, then a 28% reduction in what we're going to pay physicians, until Congress would come in and basically override it and keep things flat, not necessarily keeping up with inflation, but keep things flat for that next year. And so that was part of this law that was passed in 2015 to do away with that and put in other systems. So Medicare up until this time has been a patchwork of a variety of programs that measures the value and quality of physicians. Things like PQRS, the Physician Quality Reporting System, the Value Modifier Program, and the EHR Incentive Program, or Meaningful Use, as those that have EHRs are aware of. So through the law, Congress streamlined and improved these programs into a single merit-based incentive program, which they call MIPS. And most Medicare clinicians will initially participate in the quality payment program. Consistent with the goals of the law, this proposed rule for the law would improve the relevance and depth of Medicare's value and quality-based payments, and also increase physicians' flexibility by allowing you to have more choice in the measures and activities that are appropriate to what you provide. It allows you to be paid for providing high-quality, efficient care through success in four major areas: quality, advancing care information, clinical practice, improvement activities, and cost. So the first major piece, and on the next slide, is the quality component. So the quality component counts in the first year of this program. It's going to count for 50% of the score. You'll have 6 quality measures that you're going to be selecting, similar to what you're doing today for Meaningful Use and PQRS. But you have to have several that are high quality measures that are related to outcomes, and you have the option to choose these measures based on your specialty and based on your practice. One of the things that I can talk more about is there are specific accommodations for small groups, because this is a significant amount of work that is needed to really comply with all of this. So small groups only have to do 2 of those population measures, and that's based on their claims data, which means that you don't really have to do anything. You just submit claims. And larger groups have to have 3 measures that they utilize. A quarter of your score is going to come from advancing care information. And what this does, this is this component that really replaces the meaningful use. So that you can choose to report customizable measures that reflect how you use EHR in your day-to-day practice, with a particular emphasis on interoperability and information exchange. So what that means is, how are you able to share information with other physicians or other health systems or other healthcare providers? And the information exchange is, are you participating in a health information exchange, which may be a statewide program where all the lab tests that your patients or radiology tests that your patients may have are shared in a common pool. Unlike meaningful use, the categories will not require all or nothing measurement or quarterly reporting, so it's not quite as onerous as the prior program was. So the clinical practice improvement is the next major category, and that accounts for about 15% of your score. And so you'll be rewarded for clinical practice improvement activities such as care coordination, beneficiary engagement, and patient safety. You can select activities that match your services goals from a list of more than 90 options. In addition, you'll receive credit for participating in what's called alternative payment models and patient-centered medical homes. And we'll be talking a little bit more about that further in the hour. And the final component is cost, which is 10% of the score in the first year. It replaces the cost component of the value modifier program, and the score will be based on Medicare claims, meaning you don't have to report anything, but it would use more than 40 episode-specific measures to account for differences between specialties. So that's kind of the overview of what the new program is that replaces and consolidates all the existing programs. And what is this going to mean? What it's going to mean is that by 2018, Medicare is going to tie 90% of all payments to value. So they give you a stick, they give you a carrot, and then obviously a stick follows the carrot, so that if you don't participate, there will be penalties. So right now, the penalties exist today for meaningful use. If you're not participating in the EHR program, you're being paid, you were paid last year 1% less than your associates and had no access to the additional funds that meaningful use provided, and that would increase to a maximum of 5%. So that's ramping out, and the MACRA is coming in. You still can implement an EHR or an EMR, and that's an important piece of meeting the needs and opportunities of the future. The PQRS and value modifier, which are being replaced. If you don't report today, that can be another 4% reduction in your payments. So that if you're a larger practice, you could see up to 6% in penalties, 2% for failing to report PQRS, and 4% for not participating in the value-based modifiers. So the next slide is the timeline for the implementation of MACRA. So basically what this is saying is that the transition of implementing the MIPS program and the opportunity to participate in the advanced payment, alternate payment models. Okay, and you can see that the key components are that your physician fee schedule for Medicare essentially is going to flatten out and then not change, and then the opportunities for incentive payments and payments for participating in these programs is going to increase. When we get down the line into 9 years from now, the fee schedule will adjust depending upon your participation. So if you qualify in the APM program, it really depends on the percentage of your patients or the payments that you are getting through an eligible APM. So that and what that will mean is that if you which are quality-based payment programs, and you will get a 5% lump sum bonus from 2019 to 2024, and then your fee schedule increases beginning beginning after that will be higher than if you're not participating. So, and you don't have to deal with the whole MIPS program because you're participating in the APM program, which provides you, which is based mostly on quality. If you are in a patient-centered medical home, you've qualified as a patient-centered medical home, that is one of the key areas of being able to make that transition. So, why don't we stop here for questions? Because what I've done is I've given you a lot of information on what the new program is and the new focus is. So if anybody has any questions at this point before we get into talking about what the new opportunities are and how you can take advantage of them over the next several years to better position your practices, I'd be happy to answer those questions at this point.
Okay, and with that in mind, I want to remind the audience that there are two ways that you may ask questions at this time. You can send any questions immediately to question@healthsense.com. That's question@healthsense.com. Or I will immediately open up the lines, and all you need to do is press *6 to ask a question. So give me one moment to do that, and you may also ask live questions. Okay, if anyone would like to ask Randy a live question about MACRA incentives, anything up to this point or beyond, please press *6 on your phone at this time.
Good afternoon, Randy. Just a quick question. Is this entire presentation regarding Medicare only, or does it apply to other things such as Medicaid?
It applies to everything. The program is sponsored by Medicare, but it's taking into consideration participation in all programs. So when we go, the next part of the session, we'll talk about the different types of programs, and it'll be it's not just the Medicare programs.
Hi, Randy. Brian Bose. I see on the timeline there that MIPS looks like the bonus incentives or disincentives begin in 2019. It's my understanding that a baseline is established prior to that based on prior years. Can you speak to that a little bit?
Yes. So, it's a lot of some of it's this is transitioning from PQRS to MIPS. So some of the baseline is utilizing that information and current and other claim information that you're submitting to Medicare, and so that's that will. So when you need to be providing the information so that the adjustments that take place in 2019 are based on those prior years, so that it's not what happens in 2019 is going to be based on what happens in 2017 and somewhat to 2018. It takes them a while to.
And is that baseline established on just what you talked about in terms of what the reporting is going to be based on the various quality measures and things like that that's replacing PQRI and PQRS and meaningful use?
The baseline would be, because that's what information they have available. But then as you move into it, it expands into the other areas that we talked about.
And when does it expand into those other areas? Does that start in 2017?
Yes.
Okay.
That's my understanding. So it'll the measures, the measurement of those will be in 2017. The financial implication will be in 2019.
Thank you.
Okay. Thank you for those questions. For those who have just asked the live questions, if you could please once again press *6 to mute your phones, that would be most helpful. Any other live questions at this time? Okay, and then Nicole, out of deference to those who may have asked an online question, would you like to please read one of those questions and ask Randy?
Okay. Yes, Randy, we have a question. We're a small 5-doctor independent practice. How are we supposed to deal with all this regulation?
Okay. So just about a month ago, Health and Human Services issued a proposed rulemaking on the implementation of MACRA. So in this, they've addressed modifications for groups that have less than or 15 or less providers, those that are in rural areas and those that are in health shortage areas, federally recognized health shortage areas. So it increases the flexibility in responding to those to the measures. It's also proposing to put $20 million per year available for support of the small groups, similar to the way that money was put on the table through the regional exchanges for implementation of EMRs several years ago. And they've opened up, so the important thing is that they've opened up a dialogue for recognition in the importance of our small practices. And this is a proposal. You actually have, today's the 21st, you have a week to actually to take a look at that and to actually respond to that rulemaking proposal, or work with your medical society or other groups like that to be able to coordinate a response. And we won't know what the final rules are probably for another few months.
Okay. Thank you for that question, Paul. And Randy, one last point, just to make sure that everybody is understanding the chart. If we take 2020 as an example, since the numbers are around here at 5%, is it correct that the way that reimbursement would work in the year 2020 is that the current fee-for-service fee schedule would increase and compound at 0.5% per annum, as illustrated for 2017, 2018, and 2019. But then in 2020, the only mechanisms which appear to be mutually exclusive to increase reimbursement further would be to achieve the measures on MIPS or to participate in the APM 5% incentive program. Is that the correct understanding?
That's the way I understand it, yes.
Okay. All right. So very important, folks, as you can see, an evolution from our traditional fee-for-service only flatlining, as Randy's illustrated, very important here, 2020 and beyond. And the only way effectively to increase reimbursement at that point, and again, this is on the government-sponsored programs, you can expect commercial payers, and we're already seeing evidence of this, to follow suit with some variant of these incentives. So anyway, thank you, Randy, and in the interest of time, since we have about 23 minutes, I'll turn the floor back over to you, and we'll go ahead and mute all of the lines.
All right, so now we can go to the next slide, and so the new opportunities that are there. So the idea here is to get paid for things that you're already doing, and these are things that are available to you today. So the chronic care management, that Medicare has begun to pay for chronic care management, and basically this is maintaining. These are efforts that you're making to maintain the health of your population. So you don't. It's not face-to-face work. It's having someone that makes phone calls to the patient, make sure that they're doing their A1Cs or doing or following other guidance that you may be providing them during the course of the month and the year, and so that for about 20 minutes worth of time, you would get, depending upon where you live in practice, $40 to $50 per patient for those services. Transitional care management is another large area that currently it's estimated that there's $12 billion in preventable readmission costs. So in the first month after a patient is discharged, you can get $200 plus or minus for monitoring that patient remotely. Again, similar to the chronic care management, but working with that patient remotely to make sure that they stay out of the hospital, and that can account for it's the equivalent of several office visits with today's reimbursement, and be putting you in a position to also qualify better as you go down the road with the other programs. So now, as one of the questions was, what about commercial and Medicaid payer initiatives? We talked a little bit about PCMH, patient-centered medical home. If you participate, if you qualify as a PCMH, and you then can participate as an APM, and as we said before, that avoids the whole MIPS thing, but you've built an infrastructure in your practice to provide a different type of care, because it emphasizes a comprehensive and accessible care to patients by a team of providers. So today there are 90 plus health plans and 43 Medicaid programs that recognize PCMH and pay their providers an incentive to provide that service for their patients. And that you don't have to necessarily just be a large practice that can afford to have licensed clinical social workers or dietitians or whatever that are working in your practice and helping to be part of that team. You can still do it as if you're a smaller group as well, and be able to benefit from these things. There are some relatively small groups that have qualified as PCMH and been able to do quite well to date. And then the P4P, or pay for performance, Bridges to Excellence, has been around for a long time. And what it is it can overlap with PCMH. If you qualify as PCMH, you're most likely going to qualify for a program like Bridges to Excellence. And you can gain incentives for meeting specific quality measures, and that overlap with the other programs, but they're focused on specific insurances and the like. In one group that I worked with was in a large General Electric area, and General Electric was a big participant in Bridges to Excellence for their employees in their self-funded program, and these physicians did quite well with the incentives that were provided for taking care of those patients and meeting those measures. So the next area that we'll talk about are the risk-based contracting, and you've heard about ACOs and or accountable care organizations. Started with Medicare. In 2011, there were 64 ACOs. Last year, there were 744 ACOs, and they weren't all just Medicare shared saving program participants. They were across all the various insurance programs that are out there. And typically, it's a program that will be a joint venture between a hospital or health system and physician groups that are on staff, so that they can share, they can receive bulk payments and they're sharing risk, but that risk is spread across the physicians and the hospital. And again, you have components of the other programs that we've talked about, like the chronic care and transitional care and PCMH. All of those help you better position yourself to be a part of these types of programs. And the ACOs, some have done well and some have done okay. Bundled payments is sort of like what the hospital DRGs that started years ago, where it's a fixed cost for an episode of care. So if you're a surgical practice, you're going to do cardiac surgery. You're getting a fixed payment for all the care that's related to that, and you're in control of those expenses as much as possible, and you may benefit if the outcome is good and the costs are lower. You get to benefit. If the outcomes aren't good and the cost is higher, then it's going to cost you. So there's a risk there. And then we have capitation, which has been around for a long time, and it's essentially the per member per month payment. You get a fixed amount of money per month for every patient, whether you see them or not. You may also get a co-payment when you do see them. And capitation plans may be a smaller amount per month if it's only for the physician component, or if it's something that's in an ACO or a hospital or partnering with a hospital where it could be a much larger amount, and then you're dividing that money with other health organizations. But it's focused on the total care of the patient and eliminating unnecessary tests and procedures so that you're providing quality care, but you don't have the same incentives as you do for the fee-for-service. So what are the success factors in accomplishing all of this? So patient engagement in population health is a critical one. So it's going back to, it's almost like going back to the Marcus Welby days, where it's a high touch, creating that relationship with the patient, being more involved in their total care and identifying the gaps in their care, not just, oh, you're not feeling well, come into the office and I'll take care of what your problem is. It's looking at what's the population in need. So it's identifying those patients that are diabetic and at risk that you need to make sure that they're receiving those services that they need, or monitoring their A1Cs and blood sugar and the like to make sure that they're not getting in trouble. The quality measures at the point of care. So this is where it's the old PQRS and meaningful use, but it's the EHR. what is the EHR, what information is the EHR providing you to be able to identify what services are being provided and what the outcomes are of those services. The performance of your practice. What's the, if you have an EHR, which I'm assuming most of you do today, how are you using it in terms of the flow of the patients through your practice and the process, so that the EHR can provide a variety of things for you in terms of monitoring the patient as far as are they due for certain things? Is it time for their annual physical if they're otherwise healthy? And how is it informing you and notifying you? If you don't know ICD-10 yet, just using it in the same way that you used ICD-9, you should learn ICD-10 because it will. If you improve your coding, it's going to reduce your risk because you're going to be providing more accurate information on what your patient's problems are and be able to and improve your reimbursement as well. And then you need to, if you don't have an EHR, you need to invest in the EHR. If you have an EHR that's not providing you what you need, then you need to look at whether you should invest in a more robust EHR. And part of that are the analytics that go with it. If your EHR is basically just an electronic version of your paper chart, you're missing out on opportunities because you don't have the ability to analyze that data. And to analyze that data, you need to have data points. So if all you're doing is basically transcribing into the EHR, you may not have any data points that you're gathering to be able to do the necessary analytics. And then other opportunities are out there in terms of partnering. Health, you don't have to be acquired by a hospital or a health system. Private practices can participate in the ACOs, and be able to benefit from sharing that risk amongst a larger group of providers. It may also give you access to the success factors that we identified as far as a new EHR if that's needed, or analytical services, or training on ICD-10, et cetera. As I said, yes, you can consider your practice to be acquired by a hospital-affiliated group or some other type of large medical group, and but if that's the route you go, you want to make sure that you're going into it with your eyes open. And then private practice mergers and acquisitions, where you may merge with another private practice, and so those are the key things. So basically, to summarize, things that continue to change. Doesn't matter whether the Donald gets elected or the Hillary gets elected. Things are going to continue to change, and healthcare is going to be an issue, and efforts are going to be made to reduce costs of healthcare and to make sure that those that need it get it. Risk is here, So you can either recognize it and embrace it, or you can try to run from it. And you can only run so far because it's not Medicare, it's Medicaid. All the commercials are all going to be, participating in these types of programs. So and with Medicare, which for many of you is a significant payer, I'm sure, it's going to be participate or be penalized. And I think the same thing, you will see the same thing move into Medicaid and the commercials. We've seen over the last several years several large insurance companies that have basically said, you're no longer in our top tier of providers, so we're going to pay you less, and we're not going to encourage patients to use you, or we're not even going to credential you anymore. So it's going to become endemic across all the carriers. We talked about the opportunities to be paid for things that you're already doing. When you're making that call to a patient who's been discharged from the hospital, or you're responding to issues on patients that you have that have multiple chronic ailments, if you track what you're doing using your EHR and the like, you can get some additional compensation for those services. And then the big one is the PCMH. It's a significant change in the direction of how practices perform, but it has it's really, for all these different payment models that we're talking about that are quality based, it's really, if you go down that road, that is a significant opportunity for success and to gain the best incentives. And the practices that I've worked with that are and work with that have qualified as PCMH, the satisfaction of the providers and the staff is usually higher as well. And with PCMH, it puts you in a better position to successfully participate in ACOs and other types of programs. And it's not necessarily that you have to become a big group to do this. I've worked with some small groups of 10, maybe 10 or 15 providers that qualified as a PCMH and have done quite well. So the slide that's up now has some additional resources. The third one is that that I said you have a week to respond to the proposed rule for MACRA, and there's information in there that is important, that would be important for that. So we can take additional questions, I guess, at this time.
Okay. Based on that, I will open up the lines once more for live questions. And as a reminder, if you would like to ask a live question, please go right ahead by pressing *6 on your phone at this time. Any live questions that have not been asked? Okay, then Nicole, why don't you ask one of the questions that came in through question@healthsense.com.
Okay, great. One of the questions that we have, Randy, is what programs would be considered advanced payment models?
Okay, so those would be, those would be ones that would come from the commercial carriers in your area. And as I said, if you're a PCMH, you automatically qualify for whatever those programs are and the incentives that would come along with them. So, it's going to vary depending upon what area you're in, but there's a lot. Most of the commercial programs and some of the Medicaid programs that recognize PCMH would qualify in that.
Okay. Excellent. One more question, Nicole. Go ahead and ask that. That'll be our last one, and then we'll do a quick wrap-up.
Okay, great. The last question we have is, when will the CMS rules be finalized?
Okay. So, as I said, that is they will accept comments through the 27th, and then the final rule will probably be published in August or so, and then it would probably may not take effect until January. But they haven't formally announced the dates. But that's from prior rulemaking that I've seen in comment periods. That's usually how it goes.
Okay. All right. Thank you for the questions. And what I want to do is give you a couple of other opportunities. One of the things that is offered in concert with the webinar series is that for any practices that are interested to get a assessment of your payer contracts and value-based reimbursement, you can reach out to my partner, Charkin, at healthsense.com at the number above and bring some of the information that's listed here, and Susan will give you a quick assessment, no cost or obligation, relative to agreements, and this is a benefit that we bring to those that attend this webinar series, again, in the spirit of extra value, brought to you by Quill Healthcare. And speaking of extra value, brought to you by Quill Healthcare, there's also a discount coupon contained in these slides. Again, you can get the slides at healthsense.com/copies, and simply go to the URL specified here at quill.com/medical supplies, and you will get a discount of $20 off when you spend $150 or more on practice supplies. And this offer, as you can see, is good through August the 18th using the code specified here. Last but not least, starting at the bottom of this slide, if you would like to obtain copies of the slides, you may go to healthsense.com/copies at any time, starting right now, and you will be able to obtain copies of a PDF copy of this entire slide deck at a future date. Quill Healthcare does plan to make this entire recording of the entire webinar available for replay. We don't have a date yet, but it will be posted on the Quill Resource Center at a later time. And if you have any questions for Randy or for Quill Healthcare, simply send an email to info@healthsense.com, or you may phone the Quill Healthcare Resource Center at the number specified, or call us here at HealthSense Inc., and we will get your questions immediately over for prompt reply to Quill Healthcare. Once again, it has been a delight to host this webinar and to have you attend, and I certainly expect that understanding value-based reimbursement will be very important to your practices going forward. Look for our third quarter webinar, which will be coming during the month of September, and we will keep you apprised of what that date is and the coming topics, as there will